Hi, welcome back. This is Morgan Livier from Grand Canyon University's Bio 520 course. Today we will be talking about the renin-angiotensin-aldosterone system. So the kidneys remove waste and extra fluid from the body. The kidneys conduct many jobs, so that includes maintaining water balance in the body, maintaining osmolarity of body fluids. They regulate the quantity and concentration of extracellular fluid of the body. They maintain plasma volume. They keep the acid-base balance in the body. They filter and excrete the waste of the body, so they are going to remove waste through urine. They excrete foreign compounds also through urine. They produce the enzymatic hormone renin and the red blood cell producing hormone erythropoietin, and they convert vitamin D to its active form. So the kidney's main job really is to excrete waste in the form of urine, but all these other jobs come with that. So the functional unit of the kidney is the nephron. There's about 1 million units of nephrons in each kidney, and they're going to be bound together by connective tissue. So the nephron is the smallest unit of the kidney, and it is able to produce urine, and it's going to aid in the many jobs the kidney performs. So this pair of bean-shaped organs are actually essential for the body to function correctly. So now let's dive deeper into how the kidneys work. So there's actually three processes that occur to create urine. So glomerular filtration, tubular reabsorption, and tubular secretion all occur to get to our end product, which is excretion of urine. So first, the blood is filtered through glomerular filtration. The blood moves from the afferent arteriole into the glomerulus, where there is a non-discriminate filtration of protein-free plasma. So this basically means that most things are going to pass through the glomerular membrane, such as plasma and dissolved substances, but larger things like blood proteins and blood cells are not permeable to the glomerular membrane. So only about 20% of the membrane is actually filtered here. The rest of the 80% of blood and those items that are not filtered through are going to continue to move through the efferent arteriole and into the peritubular capillary out to the venous system. So if you see here, if you follow my mouse, entering the afferent arteriole into the glomerular capillary here. So this is where that plasma is first going to be filtered. What is filtered will go into the Bowman's capsule to get ready to be excreted, and what is not will enter back into the efferent arteriole. And then it's going to make its way down into the peritubular capillaries and eventually out to the venous system. So the next step of urine formation is tubular reabsorption. At this point, substances that were filtered through the glomerulus and entered the Bowman capsule can be actually reabsorbed through the tubular reabsorption. This movement of substances is selective, so only what the body needs is reabsorbed and sent back to the peritubular plasma to eventually make its way to the venous system. Those unwanted waste substances are not going to be reabsorbed, and they're going to exit the body through urine. So back to the Bowman's capsule here. Step 2 right here is reabsorption. So those vitamins that got filtered through but the body actually needs is going to get reabsorbed to the peritubular capillaries and sent out to the venous system. And then things that are waste will continue to be excreted. And then the next step is tubular secretion. So substances that did not get filtered out through the glomerular filtration or the through glomerular filtration are considered waste, and they can be transferred from the peritubular blood into the tubular lumen to exit the body through the urine. So that plasma that entered the afferent arteriole but didn't get to go through the glomerulus continued down to the efferent arteriole and made its way to the peritubular capillaries. So the waste that ended up entering these capillaries will be sent back through secretion to the Bowman's capsule. So that way it can be excreted. And we're really going to focus on tubular reabsorption. We have mentioned that during tubular reabsorption, products that were filtered through glomerular filtration aren't always waste. So those substances that the body needs can be reabsorbed to the peritubular plasma through tubular reabsorption. So this process is highly selective. So substances can be reabsorbed passively or through active transport. Passive reabsorption requires no energy, but active reabsorption requires some type of energy. So one way is through a sodium potassium ATPase pump and the basolateral membrane of tubular cells. So you can see in this image, we have our peritubular capillary and our tubular cells here. So passive diffusion is occurring here. You have some solutes just moving through the membrane of the cells into the interstitial fluid and then eventually into the bloodstream. And then here it is through active transport, so you need ATP in order to be transported. All right, so now we're going to go even more in depth of tubular reabsorption and look at sodium reabsorption that happens in the tubules. So of the sodium filtered out, about 99.5% of it is reabsorbed through tubular reabsorption. So sodium is reabsorbed throughout most parts of the tubule, and one of the most important places that sodium reabsorption occurs is in the distal and collecting tubules. So sodium reabsorption in these parts of the tubule play a big role in regulating extracellular fluid volume. And extracellular fluid volume plays a very big role in arterial blood pressure and potassium secretion. So sodium will be reabsorbed regardless of the sodium load of the body. Sodium load is like the maximum amount of sodium that the body has. The sodium load can be seen by extracellular fluid volume. So whenever sodium load is high, then there will be an increase in water attracted to it. And this is going to cause the extracellular fluid volume to expand, resulting in a higher blood pressure. And I'm sure you've heard people say too much salt can cause high blood pressure, and that's because wherever sodium goes, chlorine is going to follow, and that's going to be sodium chloride. And then it can also be seen whenever there's a decrease in sodium load. So extracellular fluid volume is also affected by a decrease in sodium. Less water will be in the extracellular fluid, so volume will be reduced, and that's going to cause blood pressure to be lowered. So we can conclude that blood pressure depends on sodium. So now let's talk about ways that we can regulate this sodium. So regulating mechanisms of sodium. The renin-angiotensin-aldosterone system is the best and most known hormone system that regulates sodium. So when there is a decrease in sodium chloride, extracellular fluid volume, and arterial blood pressure, granular cells in the juxtaglomerular apparatus are going to release the hormone renin into the bloodstream. So renin is a hormone that controls blood pressure. It basically tells the body that extracellular fluid volume needs to be increased in order to get the blood pressure to increase. So to get to this point, the body must increase the reabsorption of sodium. And like I mentioned before, chlorine will follow sodium's movement, so the body will be reabsorbing more sodium chloride. And this increase in sodium chloride absorption will increase water retention, and that's going to result in higher arterial pressure. I know I keep saying increase, 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 but just always remember that low blood pressure is going to result in the release of renin. It's going to increase sodium chloride reabsorption and increase blood pressure. So the graph here displays the effect of renin on arterial pressure. And you can see that blood pressure drops to hemorrhage level here. And then once renin is released from the granular cells into the bloodstream, the arterial pressure begins to increase back to safe levels. But if the renin-angiotensin system did not release that renin into the bloodstream, your arterial pressure would still be at a hemorrhage level, and that would result in harm to the patient. All right, let's look at the details of the renin-angiotensin-aldosterone system. So there are a series of events that happens before that increase in sodium reabsorption actually occurs. First, like we mentioned, renin is released from the juxtaglomerular apparatus of the kidneys. And then there is a protein in that bloodstream that is produced by the liver known as angiotensinogen. Now, renin is going to activate angiotensinogen into angiotensin 1. And then from here, angiotensin converting enzyme will convert angiotensin 1 into angiotensin 2. So let's look at this image here. So we have our blood pressure falling. So renin is going to be excreted. So renin is going to activate angiotensinogen into angiotensin 1. And then, like I said, ACE, angiotensin converting enzyme here, is going to convert angiotensin 1 into angiotensin 2. Sorry. So this is where we are right now. Angiotensin 2 is going to stimulate the adrenal cortex right here to release aldosterone. And aldosterone then stimulates an increase in sodium reabsorption. So aldosterone is going to stimulate reabsorption into the kidneys, or into the bloodstream, sorry. And that increase in sodium is going to cause more water retention, allowing the blood pressure to rise. So of course, sodium reabsorption is caused by the renin-angiotensin-aldosterone system, and that's going to result in higher blood pressure. But angiotensin 2 also has beneficial effects on blood pressure as well. So angiotensin 2, you can see here, directly affects blood pressure rising. So angiotensin 2 can increase blood pressure by stimulating thirst. It can increase arterial vasoconstriction, and it can stimulate vasopressin, which increases water reabsorption. So all of these things that angiotensin 2 causes will actually also result in blood pressure rising. So the renin-angiotensin-aldosterone system can react in the opposite way when blood pressure is too high. Whenever blood pressure exceeds normal range, the secretion of renin is inhibited. So that inhibition of renin will not allow aldosterone to be released or stimulated, and that's not going to allow the increase of sodium reabsorption. So the blood pressure will not be able to rise anymore if it's too high. Sometimes the renin-angiotensin-aldosterone system can function abnormally. So this can be seen in individuals with congestive heart failure. Congestive heart failure causes the heart to weaken, therefore cardiac output decreases and blood pressure is low, even though the plasma volume is normal. So low blood pressure is due to the failing heart, not the need for sodium. The body is going to sense the low blood pressure, and the renin-angiotensin-aldosterone system is triggered to release renin and that's going to cause an increase in the reabsorption of sodium. So basically, patients with congestive heart failure are going to have um, that it way more sodium than they need in their bloodstream, which is going to cause retention of water whenever they don't need it. And this causes patients with congestive heart failure to experience edema. And edema weakens the heart even more because it can't keep up with the extra fluid in the bloodstream. So, to help with the increase in fluid gained from the activation of the renin-angiotensin-aldosterone system, patients with congestive heart disease are often prescribed diuretics. And diuretics cause an increase in urination, which is going to cause more fluid to exit the body. Scientists have found that diuretics like acetazolamide remove excess fluid from patients experiencing congestive heart failure. So, once patients see improvement in edema symptoms after taking acetazolamide, the patients can be weaned off of the diuretic as long as the edema continues to improve. So, that's all I have today on the renin-angiotensin-aldosterone system. I hope you found it interesting and you enjoyed all my references.